Hi, and it's me, Dr. Mohammed Kazafi. I want to present one more topic and the case in front of you people. For the sake of your interest, this topic is associated with one case, and I will present with the case. And you are watching Dr. Mohammed Kazafi Views, and the 35-year-old male carpenter presented with the sudden onset quadriparesis lasting 5 minutes, and after hyperextending his neck while at work, the patient reported a similar episode of the transit limb weakness after cervical and chiropractic manipulation 6 months prior, and upon further questioning he reported increased frequency of the urination, and positive finding on the examination include graded cervical motion and increased turn in all four extremities, and the 3 plus hyperreflexia in bilateral bicep, tricep, knee, and the ankle. And here my provisional diagnosis is the atlanto axial dislocation, and which happened. It was started before, and he experienced some kind of dislocation before, but now he is presenting new. So the differential diagnosis here, like the congenital atlanto-axial dislocation, my provisional diagnosis. Second thing may be the os odontoideum, and a trauma, odontoid fracture. Tumor may be the foramen magnum meningioma or schwannoma or ependymoma or clival malignancy with extension into the craniovertebral junction. Infectious may be Grizzle syndrome, and the inflammation may be rheumatoid pannus. Here, I want to present to you these few pictures here. You can appreciate here there is one example for the CT scan, sagittal views, and definitely few X-rays. I just want to explain here that different kind of the radiological pictures, and here you can assess, there you can appreciate there is a dislocation or instability, definitely because of the fracture or some other reason. So these angles are very, very important to understand the atlanto-axial dislocations. And here you can see the post-operative X-ray, which is showing there is a C1, C2 posterior fixation associated. We can plus minus and with the means occipital fusion. This is very much in our practice. Here you can appreciate there is a fracture here, and there's a traumatic case. I just wanted to present in front of you. Before that everything we will start. Here you can see the narrowing of the canal at the atlanto-axial junction, and you can appreciate here. So this is the idea. Now I want to go back to the case and then the topic. I think here you can appreciate more what happened, and the arrow, the green arrow showing the pressure from the interior, and the blue arrow showing the pressure from the posterior, and you can appreciate how much deformity or the dislocation happen at the atlanto-axial dislocation. It happens in the adults and the children. And just I want to start the presentation for this case. So here for the image description, CT scan of the craniovertebral junction, inflection and extension, and demonstrating a reducible atlanto-axial dislocation with the dents completely in extension, and the further workup such as the MRI, cervical spine help define relationship of the cervico-medullary junction dens and the posterior arch of the C1 and C2 in relation to the neuronal and the vascular structure, and the dynamic flexion and extension x-rays of the cervical spine provide a pre-operative anatomic roadmap to compare with the intraoperative anatomy and imaging, and the routine blood work to ensure that the patient is not anemic and the protein and calories malnourished and the actively infected include the CBC or the PTINR and APATT. Pathophysiology, we have to understand here a C1, C2 facet joint from the most mobile joints form the most mobile segment of the spine and are thus prone to developing instability and the dislocation at this level, predisposing the cervicomedullary junction to compression from a mobile dens and causing injuries ranging from the transit quadriparesis to the respiratory difficulties and the sudden death. So the surface of the normal atlanto-axial facet joints are relatively flat and the parallel, and the movement in this joint include angular, rotational, linear, and the translational motion. However, anterior movements of the axis vertebra is restricted by the anterior arch of the C1 with the odontoid is normal. I want to repeat, the surface of the normal atlanto-axial facet joints are relatively flat and parallel, and the movement in these joints include angular, rotational, linear, and the translational motion. So, however, anterior movement of the axis vertebra is restricted by the anterior arch of the C1 with the odontoid is normal, and the posterior movement is restricted by the cruciate ligament and largely by the transverse ligament, and the rotatory movement is restricted by the alar ligament. So it is possible that inadequate extension of the C2 to C1 as a result of pain or the muscle spasm and minimizing C2 mobility even with adequate extension. And atlanto-axial dislocation can be evaluated by measuring the basion-dense interval, and the atlanto-axial dislocation are classified into 4 varieties depend upon the direction and the plan of the dislocation. So the anterior-posterior, rotatory, central, and the misdislocation here. Here I want to present you a small thing in front of you people so you can appreciate here that. So you can appreciate there is a drawing illustrate and the cervical radiographic technique for the diagnosis of the atlanto-occipital dislocation, and the basion-dense interval is very important and is abnormal in the presence of the displacement between the bones. As you know, the treatment options are like the posterior fusion is the treatment of the choice for the reducible atlanto-axial dislocation, and if reducible, an odontectomy followed by the posterior fusion may be required if the anatomy at the occipito-atlanto-axial region is normal on X-ray, and the dislocation should be reducible by the cervical traction or during surgery by mobilizing the joint. Approach anterior, such as the transoral decompression of the odontoid, or the posterior, the bone graft between the occiput C1 lamina and C2 lamina, C1 and C2 rib graft, and interlaminar wiring or the modern instrument can be used, such as the clamps, and the C1 C2 interspinous interlaminar wedge graft and modified Galeal such as the instrument, and the semi-rigid occipital loop and the sublaminar cables C1, C2 transarticular screws, C1 lateral mass to C2 translamellar screws, and the rods, and the C1 lateral mass to C2 pars screws, and with rods, and the occipital plates such as the C1 lateral mass screw, C2 pars screw, and the rods. So here instrument you can choose according to the need of the need of the surgery. You can use the rods, you can use the plates, you can put the screws, and you can mix it. You can attach with the C1 to C2, or the occipit with C1 with C2, or occipit with C2 only, or sorry, C3, or you can miss the C2 in middle. So it is a lot of thing in the, for example, occipital plate with the lateral mass screw in the C1, and the pars for the C2, for the pars screw in the C2. So these are the different options for you, and you can utilize these options and for your need here. And I want to show you here, there is a little classification of the atlanto-occipital dislocation. You can appreciate here the three types: type 1, type 2, and the type 3 atlanto-axial dislocation. And here you can appreciate that the classification system of the atlanto-occipital dislocation type 1, or anterior dislocation of the occiput with respect to the atlas, and the type 2, or the vertical displacement, type 3, or the posterior displacement. So this is enough to. So you know the surgical technique required here. The fiber optic intubation is performed, and the baseline somatosensory evoked potential and the motor evoked potential while still spines are the obtained. Patient is turned prone in chest roll with the cervical alignment maintained in the Mayfield head clamp to maintain neutral occipito-cervical position. If autograft is required, the harvest site is included in the prepped area, and the midline incision extends from the inion to the lowest level to be fused, and during subperiosteal dissection, a cuff of fascia is left at the inion for subsequent closure, ensuring that the occipital plate is covered by enough soft tissue to prevent hardware erosion, and that decompression is performed as indicated, and the bone set for use as an autograft. And occipital fusion can be performed using wiring in and out bottom plate, or the occipital condyle screw fusion fixation, and the midline keel is actually usually between 10 and 14 millimeter thick, and the screws of the 2.5 millimeter can be placed to anchor the occipital plate, and the drill in increment of the 2 millimeter after an initial depth of the 8 millimeter to avoid injury to the posterior fossa structure. And the paramedian bone in this region is not as thick as the midline keel, so the cervical instrumentation can then be placed and incorporated into the occipital plate using a rod bent to the required shape. And usually you know that the flexible endotracheal tube stellate is the template before bending, and a rod or the Steinman pin and a pins you can use. If the C2 anatomy is unfavorable for the placement of the either pars or a pedicle screw, then pass the sublaminar cable under the lamina and place lateral mass screw at the C3, which is very strong, thick, and you can get a good results. And but if you can put in the past, I'm not forcing you to go to a C3, but I'm telling you, you can use the C2 pass, but definitely you can use the lateral mass screw for the C3 as well if you need it. You know that the rod from the C3 to the occiput, it's a little long, but definitely, and you can use this. I want to show you one thing here. This is the entry point. You can appreciate here. This is the entry point of the and the direction which shows very clearly to you. Preoperative review the depth of the midline, suboccipital keel and thickness of the paramedian cranium and the course of the vertebral artery to minimize injury during the surgery, and verify a neutral occipital cervical relationship before looking in the construct. Complication avoidance and the management. I just want to present some complications and some management in front of you, such as the inability to intubate, worsening or the neurological status or the intraoperative SSEP changes, and the gross instability at the craniovertebral junction. So the preoperative evaluation, fiber optic intubation, and patient should be in the dynamic traction, and preoperative assessment of best position and awake position or an stabilized C1 or C2 with the towel clamp and during the sharp muscle dissection. So these are the management views. In excessive, and here if you see the excessively means if you are finding there's an inability to intubate and worsening or the neurological status or intraoperative or SSEP, somatosensory evoked potential changes. So gross instability at the craniovertebral junction. So preoperative evaluation and fiber optic intubation is a management for this, and the patient should be in the dynamic traction, and the preoperative assessment of the best position should be used, and awake positioning is also a choice, and the stabilizing the C1 to C2 with the towel clamp during sharp muscle dissection, because you can avoid the complication. Excessive bleeding with C1 lateral mass exposure, subperiosteal dissection behind the C1 posterior arch with progressive bipolar coagulation of the venous plexus. Last resort is C2 ganglionectomy, and to visualize the dorsal rostral C1 lateral mass. And the bleeding from the vertebral artery in the foramen, so place a screw and leave in situ, and do not place a screw on the other side and need angiogram. And the bleeding from the occipital screw placement, then the preoperative measurement of the occipital keel and the position of the transverse sinus to gauge depth of the screw and avoid sinus, and place hemostats agent and oxidized cellulose and the flat head screws. If the CSF egress from the occipital screw, pack with the hemostat agent and place a screw, and if from spinal dural tear, and identify and close the leak with the surgical manner. If you and definitely we as a neurosurgeon, any surgeon knows that with a lot of things you can do. And the wire cutting through the arches of the atlas during the sublaminar wiring, so the rule out of the bifid C1 arch and the hypoplasia on the preoperative image, so it will avoid that kind of complication. And if the hypoglossal nerve injury and the pharyngeal penetration, then the careful preoperative assessment of the C1 screw length, and must obtain post-operative CT scan if a screw is too long and it will need to be withdrawn, and loss of alignment, screw fracture. For example, loss of alignment and screw fracture or the pull out, then the redo procedure, and if no instrumentation performed, place in attraction and halo vest. And if the swallowing or breathing issue, then two flex position of the fusion, and will need the fusion reposition to improve airway and avoid distraction in the patient flex position. So these are the few things which I wanted to present in front of you. I hope you like it. If you like it, please subscribe and share with others.